All right, welcome to the Fringe. Excited to be here. My name is Mitch Hauschildt. So those of you guys I haven't met, so this is actually my first time hosting our podcast. So probably makes sense for me to introduce myself a little bit before we jump into Corey, our guest, and the conversation we have ahead of us. So I am the sports medicine and clinical director at Fringe, and so I've got a long history of working in the sports medicine field as an athletic trainer and a strength coach. Worked with a number of different companies doing continuing education and things like that. And so my role at Fringe is to really support our clinical staff and make sure they have all the education they need, all the product they need, and everything they needs to be put in place for them to be successful. But I am also still a practicing clinician. So I'm the rehab and injury prevention coordinator at Missouri State University. So my days are spent doing injury prevention and rehab on Division I athletes, which keeps me in the weeds and busy. This is an interesting time to be in college athletics, and I won't get off on that soapbox unless Corey and I end up going there today. I don't know, but NCAA athletics is an interesting place to be, but it keeps me busy. But also I love it because I have a lab every single day. I get to use our products and I get to use our stuff and then relay a lot of that information back to our clinical friends. So anyway, I'm excited to be here, excited to be hosting for the first time today, and I'm super stoked to have Corey Tremble with us. Corey is a longtime friend of mine, has a long history of working in professional baseball, but I'm going to kick it to him and let him do his own intro. And Corey, I'm just going to say this because I know you're going to be pretty humble with your intro, but I actually want you to not be humble and kind of give us quite a bit of your background and your evolution in pro baseball and where you've been and where you've landed now, because I think that story is important for helping
Sure.
us understand, what we're doing and how you're using Fringe and how your team is using it and those kinds of things. And that'll kind of set the stage for our conversation going forward.
Yeah, no, great. Thanks, Mitch. Love being on the Fringe here today. So a little bit about me, right? So name is Corey Tremble. I've worked in professional baseball the last 20 years. Currently, I'm the director of medical operations for the Miami Marlins. So in that role, I oversee the entire medical umbrella from the major league team all the way down to our academy in the Dominican Republic. So anywhere between 20 plus direct reports with a bunch of physicians and the whole paradigm of the sports medicine contingent. So it's a really great opportunity. I'm in my second year here. Prior to that, I spent 1 year with the Texas Rangers as a consultant, and then more of their leadership in their minor league system. And then prior to that was 17 years with the Detroit Tigers, a couple different roles of minor league athletic trainer started out with, and then I became the minor league medical and rehab coordinator over there. So again, most of my experience is with baseball, which I think really plays into what Fringe does and the products they put out, because we are constantly chasing this scary thing called workload, and we're constantly chasing down fatigue and trying to find ways to stack the deck any way we can. So, and just a little bit more about my day-to-day role. So now I'm not player facing as I once was, but what I'm able to do in this role, I'm leveraging the doctorate that I achieved at Florida International University. So pause up in academic and entrepreneurial leadership. So really utilizing that, leveraging that in creating process and creating feedback loops and mentoring and mentee type programming, and really starting to zooming out even past 30,000 feet and really trying to look at, hey, how can we create a department that's entrenched in trust, integrity, and player-centered approach? And that's what we try to do with the Marlins. And that's where products, like red light therapy has really become a huge piece to our day-to-day. And that's why I'm excited to be here to talk to Mitch and hopefully answer some questions and have some pretty
Yeah,
good conversation here.
for sure. So first of all, I do appreciate you shouting out FIU and as a Conference USA member
There you
at
go.
Missouri State. I mean, I'll take it because I want to support other conference schools, but also because they're in our conference,
There you
can't give
go.
them too many props. But
That's right.
with the constant change, and we've only been at Conference USA 1 year, so it's not like we have a long history with those guys. But
That's right.
it is funny how our paths cross. But you and I, when we first met, you were the rehab coordinator at with the Tigers,
Yep.
and you happened to stumble into a tape class I was teaching, and
That's right.
we started
Yep.
talking. You guys had some of our guys at Missouri State, former guys that were in your system, and so it's that's really what our background is and how we met. Just giving people kind of a little behind the scenes there, but I love what you were just saying, and I'm a little bit jealous. And we were talking offline of just how I think a lot of our clinical friends that are listening to this, watching this, I think we can kind of relate. And you've had this natural evolution of patient care, now moving into a leadership role, and maybe expand on that just a little bit of how that has worked for you. And I think a lot of us are kind of in that stage, if we've been practicing a while, where maybe patient care is fun, but it's not amazing. And we're looking at kind of what's next. And it seems like you found that spot. So maybe expand on that just a little bit.
Sure. And that was really, I think everybody in their career has these lulls where they run into kind of a wall and go like, is this what I really want to continue doing? And it kind of happened throughout my career, especially early on with the Detroit Tigers. And instead of pivoting or trying to think of something different to do or a different avenue to do, I just kind of leaned into how to make the zoomed in program or the athlete better. So it was taking a ton of courses, or it was taking a ton of Con Ed here or there, reading a bunch of this, but it really wasn't anything next level or bigger picture. It was just continuing to kind of shift the vision of what I was currently doing. So that was great to some extent, but it really didn't feed the fire that I was kind of getting into later on. And I just started having higher level conversations with really, really intelligent people in a lot of leadership spaces. And it just seemed that was going to be an avenue that was going to fulfill that hunger that I had, but also kind of allow a bigger picture mentality that could affect growth throughout an entire department. And I think that's in a lot of our sports medicine settings, you just go from an assistant athletic trainer to a head athletic trainer to a director of athletic training or whatever that
For
step
sure.
is. And it's has
Yeah.
nothing to do with more than time served, and probably management or upper level leadership thinks you do a good job. So yeah, they'll
Yeah.
probably do a good job on the next step. And
Yeah.
I'd seen that fail because it was just like a higher paycheck of the same messaging.
Yeah.
And, I felt personally, if we were going to do something bigger and better in the profession, if the Miami Marlins were going to take a next step, we were going to have to reimagine and look at it in a different way. So that's where my day to day is filled with how can I mentor my younger clinicians to find out what makes them tick and put them in the position to get to what they want. For so many years, I just pushed on my staff what I wanted out of my career, and that's just not staff development, right? And then it's also okay, if we have one way of thinking, if everybody's thinking the same, nobody's thinking, right? And that's where some of these different modalities, these different trains of thought can really come into play. Because if everybody is just coming through the same system and we're just going to do A, B, and C because that's the Marlin way, well, that's not cutting edge. That's not going to be uh, a way that sports medicine can leverage what they do to help create a competitive advantage amongst the competition. So to me, it's like, all right, if we're going to be here, we need to have a forum where everybody can talk about what they've seen, all their experiences, all their knowledge, and really bring that back to the forefront of what we're trying to do, which is put the player in the center of all of our decisions, right? So that's what's really exciting about this, because it's never a no answer or a yes answer, it's a why. And it's constantly
For
just,
sure.
pummeling the staff with a why, until we come up with this great answer. And now it's like, okay, here is what we're going to do for our athletes. This is how we're going to treat our athletes. Here's how we're going to get them back faster and safer.
Yeah, I mean, I love that, and it is interesting what you said, right? Of at least in the sports medicine world, of assistant athletic trainer to head athletic trainer to director, like that's the way it's always been. And it's
Right.
just sort of this, and especially in pro baseball, right? And
For sure.
I,
That's
I, I,
especially,
I
yep.
yeah, I haven't been in pro baseball a ton, but I did early in my career, and you could see it was like, okay, you start off in rookie ball, and you work for $18,000 a year on a 9-month
Yep.
contract, and then if you survive that for a couple of years, you might get promoted to low A, and then high A, and then and I remember thinking at the time when I was in grad school of, man, maybe this is what I want to do, but the guy that had been in AAA had been there for 14 years, and I was like,
Yeah,
do
right.
I really want to go through this grind of the minor league system for 14 years, hoping to get to a spot in the big leagues just so I can then walk out on the mound, on national TV every now and then and look cool?
No
Like,
doubt.
is that worth it for me? For me, I decided it wasn't. And I don't fault
Right.
anybody who it is worth it for them. But to your point, I have seen in recent years, and I've seen it with several different organizations, obviously what you're doing with the Marlins, of now it's more, I think everybody's recognizing it's not just about having an athletic trainer, having a strength coach, and just seeing them evolve over time. Now it's really looking at what's the bigger picture look like. And so for you in this role, now you not only have athletic trainers, but we've got strength coaches that are involved. We've got your
Yep.
physicians, we've got dietitians, you've got this
Oh, yeah.
team and that team approach, which is wild to think about how that's evolved in the last 20, 25 years. Um, and then I'm guessing you've got some sports scientists, because you
Oh,
mentioned
yeah.
workload, and I can touch
Yep.
on workload here in a minute, but you mentioned workload. I mean, like all those pieces. So, maybe expand on that a little bit too, of just what is
Sure.
that, you know, uh, now we've got this new kind of look. And, I mean, I know a few years ago, just to kind of name names, I mean, the Yankees did it with Eric Cressy, have kind of
Yep.
taken a different approach. And it seems like that is sort of this evolution in pro baseball world.
Yeah, and to see it evolve over the last 20 years is just it's bananas, really. I mean, just to see where things were in the early 2000s to where we're at now. When we're holding our major league performance meeting before every game, it has 6 athletic trainers in it. It has 2 physical therapists in it. It has 2 dietitians in it. It has
Hmm.
3 strength conditioning coaches in it. It has our GM in it. It has our pitching coach in it. So it's no longer just the head athletic trainer writing down on a piece of paper, all right, well, this guy is going to do this today. All right, let's get it done. Those days are done. And I mean, to think about it, I know a lot of different paradigms across the board use like the pit crew type mentality, but you would not have one person doing the gas and the tires and the everything else in the pit crew. And for so long baseball was just that. I mean,
Hmm.
there wasn't even an assistant on every team until in the 80s and into the 90s. And then now, we have one of the more robust staffs, and we travel, what is it, 5 athletic trainers, not including myself. So 5 athletic trainers that work on our team of 26, 1 physical therapist, 3 strength coaches, and 2 dietitians. So again, it's just so
And that's
robust.
just with your big
That's
league
just the
club,
major league
right?
team. That's just the
That's
major league
just the
team. And then
major league
everybody
team, and
else
you've got a
has
roster of 26. Is that right?
26, yeah.
Okay.
And then we have our facility in Jupiter, our Jupiter Academy, that has
Yeah.
4 physical therapists and 2 athletic trainers and 4 strength coaches and 3 dietitians, so that when they're on rehab, that's where they go. And we're lucky because it's only an hour and a half up the road. But yeah, it's just grown. Now, how is that? How has that changed, the vision, especially of somebody in sports medicine? Because, for lack of a better term, like sports medicine was always king. We have been around the longest. We have always had the strongest voice. We have a lot of implication to the roster in whatever sport. Like, is this guy going to play or not? The dietitian really doesn't have that kind of juice. So, for a long time, athletic trainers, well, we knew that, right? Like sports medicine staffs knew that we had the biggest, piece
Mhm.
to the pie and the strongest voice. And I think what ended up happening was we're starting to phase that group of clinicians out, especially in baseball, that are like my way or the highway. I'm the king of this group, and now it's a much more collaborative, much more inclusive.
Yeah.
We make sure that we touch every single department on every single player in our lineup to know that they're good to go from nutrition, they're good to go from strength conditioning, they're good to go from sports medicine. Because again, this is it's creating such a better net for the player to have success, right?
Yeah.
If we're fueling them better, if we're helping them recover better, if we're doing strategies in the strength conditioning side of things to not just maintain their strength, but gain strength during the season. I think that's one of the biggest myths in all of baseball, that people say, "Oh, we just want to maintain during the season." So you're going to tell me that we're just going to take the next 6 months of a 12-month year and just maintain our strength? We're not going to do
Right.
anything to try to
Not
make you
wise.
stronger?
Yeah.
And then you're going to take a month off at the end of the season. So you're going to tell me that in a 12-month calendar year, you're going to try to get stronger less than you're not going to try to get stronger.
Right. For
And
sure.
it's just changing that mentality and understanding that there's so much value in each one of these spaces to help sports medicine. I think that that's where people get lost in this like power struggle at times. It's if they're dialed in, if the player is dialed in with their nutrition, it helps injury prevention. If they're
Hmm.
bigger, faster, stronger, it helps with injury prevention. If
For
they
sure.
have great mental health and wellness, it helps injury prevention. So we are really just we're the bystander in a lot of it on the sports medicine
Yeah.
side. I know we like to take a lot of the credit, but it in honesty, it's all these other
Mhm.
spaces that are allowing us to have the good results on the back end on paper.
Right. Well, and we've evolved as athletic trainers really to primary care physicians, to use sort of analogy, right? Like in our
Sure.
current world, the PCP in sort of a normal healthcare is the
Mhm.
one who's just anymore is just kind of tying everything together. They're making
Yep.
sure their medications aren't are have proper interactions. But at the end of the day, they're not. I mean, PCPs aren't looking at a lot of X-rays and casting people or
Right.
MRIs or whatever. They're not handling heart conditions. They're referring out to cardiology or whatever else.
Mhm.
I mean, that's really kind of what we've evolved to, right? Is we're the primary
For
care,
sure.
we're the main contact point, but at
Yep.
the end of the day, we're referring to PTs, our sports psychologists, our registered dietitian, our strength coaches, and really tying those pieces together in that model.
No doubt.
And I love it, and a lot of that's trickled down to our world as well, even in a mid-major Division 1, where we don't have nearly the resources that you guys do, but we are doing things differently, and we
For
are,
sure.
one of the big evolutions we've had in the last few years, at least in our setting, is we're now involved in conversations before we offer scholarships, which
Yeah.
for the bulk of my career, we never did. It was
Right.
coaches would recruit kids and then they would come in and then we would see what kind of damaged goods we had rolling in. Well, then a few years ago, the NCAA made this rule with the transfer portal that when you had 4-4 transfers, so if a kid transfers from one 4-year school to another 4-year school,
Yeah.
that if we offer them a scholarship as the second 4-year school that they're transferring into, regardless of whether they play or not, the minute they step foot on campus, that scholarship is good until they leave our
Right.
campus. And it counts against our coach's scholarship count for that team. So suddenly they were like, whoa, wait a second. I don't want to bring in a kid who's had
Right.
3 knee surgeries because if they can't play here now, I've just
Yeah.
wasted all that money and time. So now all of a sudden they want to come in an official visit. Well, we have to do full evaluations, which actually we appreciate because now we at least know what we're getting ourselves into.
No doubt.
Um,
No doubt.
so that's been good. And we've been able to adopt that really from the pro model. So we're seeing that really trickle down to my world. I also do have to say too, I do want to get into a little bit more kind of nitty gritty of
Yeah, for sure.
practice, but I also want to acknowledge, and I think about this all the time when I travel and teach courses, because I know we have like some hospital-based physical therapists or some chiropractors
Mhm.
that are kind of one-man shows that are sitting here listening to this going, man, it must be nice to be in those guys' world. And I'll acknowledge that, right? Like
For sure.
I
For
tell
sure.
I tell people all the time this past weekend, I was teaching a course down in Dallas, and we were talking about something, and they were asking me how I do something post-operative. I'm like, well, the day after surgery, we do this and this and this and this, and I have to stop and go, that's assuming you get your patients the day after surgery.
Yeah,
And they were
right.
like, we don't get them for 6 weeks. I'm like, I'm
Yeah.
so sorry. I don't know how you function in that world,
No.
because you're just chasing your tail at that point. Where
Right.
I get on top of things, we can be proactive with the staff that we have, with the mindset that we have, that allows us to do those things. But I want to acknowledge that not everybody, we do. If
No
you
doubt.
step back, you and I do live in a pretty cool world of being able
Mhm.
to be proactive and get on top of things early and have access to a lot of resources that a lot of people don't have.
Sure.
But I always tell people, that are in maybe a more traditional outpatient PT or OT practice. Just because you don't have all those people in your clinic doesn't mean you can't have those resources. And you got to go out and find the chiropractors in your neighborhood. You got to find the dietitians or the nutritionists that are willing to work with you, or the personal trainers that do those things, because that's true patient care, right? And that's really what we're all
No doubt.
looking for.
Yeah. And
So,
to your point, I mean, I was mainly speaking on the major league level, but at the minor league level, we're still a one-man band for the most part in a
right,
lot of spots,
for
right?
sure.
So it is that one athletic
Especially in the
trainer.
Dominican, right? I've been down
No
there too.
doubt.
Like
Yep.
that's a
Yep.
different world altogether.
Yep. So, and I think that's, we glorify and we pedestal the highest level, the major leagues, the NFL, things like that. But for the majority of our players, you'll never see them on TV, right? And they're
Right.
still being cared for by an athletic trainer and a strength coach. Now it's just one-on-one at each level, which is also robust to some settings and all that. But there's a much more, how do I leverage different modalities? How do I leverage different things that I have at my disposal, that because I only have one set of hands. So how do I
Yeah.
do some sort of Therex with this player? How do I do a manual therapy with this player? And how do I also get this player going? Now, at the major league level, each person can have two people. But down at the minor league level, and this is where what we purchase and what we give to our athletic trainers and our strength coaches and our dietitians at the minor league levels is so important, because we also can't just throw everything at them and say, here, make sure that you travel with all of this equipment. So we really have to be intentional of what we're buying, why we're buying it, and how it's benefiting our players day to day.
For sure. Is there a stat, and maybe this doesn't exist, and I just have been around enough pro baseball to kind of know how the system works more than I think the average person. But is there a stat of like how many players sign pro contracts, whether that's
Mm-hmm.
coming out of Central America, Venezuela,
Sure.
Dominican, or they get drafted? How many guys are signing pro contracts within an organization that actually make it to the big leagues?
Yeah.
Is that 1 in 10? Is that 1 in 20? Is there a stat out there? I'm just curious if there
There
is.
is, I don't know it off the top of my head, but the one I do know, and I mention this a lot, is that if in the draft, now the draft, when I started, it was 50 rounds. And back then
Right.
it was,
It was
if you could
huge.
get if you could get 5 players out of that to play in the big leagues, it was an unbelievable draft.
Yeah.
If now we have 20, if we can get 2 to 4 that play in the big leagues from a draft class, that is unbelievable. So you go, well, I mean, that's terrible odds. And it's like, well, yeah, but you don't know where those 2 or 4 are going to come from. That's number one. And
Mm.
unfortunately, or fortunately, however you want to look at it, we still have to go and play a game every night. And we need players that might not be as good as that top prospect in the minor leagues, but we need somebody to help fill out the team. And the great thing about baseball is, for every first rounder that makes it, there's a 20th rounder that makes it. So
That is
you
true.
never know once we get here, and the playing field shifts quite dramatically once they get here, because at the end of the day, you may have more opportunities or a longer runway if you're a higher pick or a higher paid minor league player. But at the end of the day, it's a performance-based profession. And if you perform, you're going to get opportunity. So, but yeah, it's very difficult. The vast majority, over 90% of the players will never make it to the big leagues.
Yeah, and you said it. I wasn't going to say it, but I think you at least alluded to it, that there's a lot of players within the farm systems that I think front offices will acknowledge they will never ever play at the big league level or make a step forward, but they need them to fill a
Sure,
roster to allow the
sure.
2 or 3 that are on that current team to continue to develop and to get at bats and to get work. And without fielding that entire team, those guys don't develop into the big leaguers
Right.
that you need them to. And
Exactly.
that's sort of the way the system works. Even if people don't kind of realize that's kind of where it's at, right?
Yeah, for sure. For
Yeah.
sure.
So, okay. Well, shifting gears a little bit,
Yep.
I could continue to talk about that stuff all day long, but I do want to talk a little bit about practice. And I
Yep.
know, you said that you aren't necessarily athlete facing anymore. You're not involved in a lot of direct patient care. But that's really only been for the last year or two that you've moved
Yeah,
into that
right.
kind of a role. So, how would you describe, your philosophy? I know, just an example, when people ask me, like, what's your practice philosophy? I'm a movement based guy. I believe that
Yep.
the faster we get people moving after an injury, the better off they are. So, all of the other stuff, the manual therapy, the dry needling, the red light therapy, the rock tape, the stuff, all the other stuff that I do really is just a means to an end to get people moving, because that's how I
Yep.
believe in my philosophy. It's not the same for everybody, but that's my philosophy of how we get people better. If you were to describe your practice philosophy, what does that look like? And just so people kind of understand what your mindset is.
Sure. And I think it's shifted over the years. I think when I got into baseball early on, it was so manual therapy minded, and we were going to just make guys' tissue feel better, right? That was the biggest thing. Hey, soft tissue, I'll do some massage work on this. I'll do some intervention to help them just feel better. And it was like, well, why are you coming in like every 3 or 4 days, like consistently? I guess I'm not doing a very good job of making you feel better. So I think what shifted then was, to your point, to more movement based. The body wants to just move. Like, muscles don't know anything
For
besides
sure.
contracting and not contracting, right? Like, relax and contract. That's what muscles do. They don't know what's creating it. They don't know if it's a run. They don't know if it's a jog. They don't know if it's a lift. They just know that, oh, we're using our hamstrings. The hamstring has to contract. Great. So now it's shifted to movement. And I thought that was a great kind of segue into, now it's just our philosophy with the Marlins, and this comes from our strength and conditioning department, comes from our medical department, is we are going to make tissue do what it's supposed to do, and we're going to load tissue. We're going to load tissue, and I think that's been the biggest eye opening, because I might not be very smart, but I can hire very smart people, and that's what I was able to do with the Marlins, and having so many different having this collaboration of these different thought processes that we had across the board from all these different people that we brought into the organization was just so eye-opening to how this person looks at things and how that person looks at things. And then we were really starting to hone in and kind of figured out that our philosophy is, we want to load tissue. We want to make sure that if we're going to get the most out of our athletes, we need to make sure that they can accept that load. They're robust. They are able to have that capacity. They're able to have the ability to increase their volume and accept the intensity that we're asking them to do it on. And I think that that's what's been the biggest shift, from the guy just laying on the table to now, hey, look, if you're going to lay on the table and we're going to do some things, that's great, but we're going to load that tissue afterwards. And I think that that's been the biggest benefit to my career, is getting away from the mindset and being scared of, oh, if we load the tissue too much, that's going to hurt them,
Mm.
versus, no, actually, you load the tissue more often, more effectively, they're going to be more robust. They're actually going to be a better athlete. So I think that that's the biggest shift for me, has been, let's get them, to your point, let's get them moving. But also, you can't just say that somebody that's really mobile is just going to be a great high level athlete. They have to be mobile, and they
Mm.
have to be able to have strength and tissue tolerance on top of that. So yeah, going from basically get off the table to get moving and getting stronger. That's been kind of
I,
my path.
I love that. And I think, that's part of the reason why you and I have gotten along over the years, is I think we see
Yep.
the world, the therapy world in similar ways of, we need passive modalities, we need tools, we need soft tissue work, because they do allow us to do some things. But at the same
Yep.
token, loading tissue is king, right? And that's
Yep.
that's the
Sure
ultimate
is.
goal with all this. Now, I'm curious, because you say we got to load tissue, but then that this word that has come up, especially in pro sports, over and
Hmm.
over and over again. You said it was like workload, right?
Sure.
And it's
Sure.
funny because, especially in pro baseball, you go back, like, and like, generations are all different, right? But you go back 50 years and you'd have guys that are throwing, 120, 150 pitches on an outing, and no big deal. They'd come back 3 or 4 days later and do it all over again. And now everything
Yeah.
is all about, how do we manage workload so we manage tissue quality and we don't put them at risk for injuries. So how do you balance those two worlds of, like, we have to load tissue, but we're also managing workload? What does that look like?
Sure. And I think you have to be really strategic about it. And you also have to look at it from, I think, just a slightly different lens than a lot of people look at workload. I think that workload the minute you say that it's got like this negative connotation to it, and
For
it's
sure,
like, oh,
right?
we're gonna stop players from playing, and
Yeah.
that's been from day one. That's what we've kind of talked about, and it's like, no, reimagine it. We're going to track workload to give you more, give you the ability to do more. We're going to we're going to take away some of this fluff that might just be adding to this chronic fatigue that you're having. And
Mm,
we're just going to be really intentional with X, Y, and Z. That's going to be your
right.
bigger bang for your buck. So instead of the 2-hour lift, we're going to do a 15-minute lift. Instead of
Love that.
doing rolling out for 30 minutes and then doing this for 30 minutes. Let's figure out, how much time do you really need to prep the tissue? How much time do you
Yep.
really need to put the tissue under tension? And let's get minimum, effective dose across the board in everything we do. Same thing with throwing. We've reimagined some of that, and especially our organization, we've had a lot of different initiatives come through that are very different than a lot of other organizations. So like in the minor leagues, for instance, our relief pitchers don't throw before the game. Historically, you go and you play catch and you hit batting practice and all this kind of stuff at like 3 or 4 o'clock. And we just sat around and said, why would somebody go out and throw, and who knows how much kind of effort, because there's not really a great way of tracking effort on throws, even without just straight up radar guns. But why would you let him go throw high intensity at like 3 o'clock and then not throw again until like 8:30 or 9 at night? It made no
Yeah.
sense. Why
Yeah.
sprint at 3 o'clock in the afternoon for your 8 o'clock race? It really didn't make a lot of sense. So now what we do, if a guy doesn't throw in the game and wants to throw, they play catch after the game.
Mhm.
And so it's just reimagining the time and going like, why should we not be putting all of our eggs in the basket of being the best version of ourselves when we're asked to do that in competitive game situations?
Yeah, so
And
what I'm hearing from you is intentionality, right? So
no doubt, no
let's
doubt,
get rid of the junk, right? Let's get rid of
absolutely.
why are we playing catch just to play catch? Why are we
Yeah.
running just to run?
Why are we taking
And
an extra 40 swings for no reason? Just because, oh,
right,
it's part of my routine? Well, let's
right.
talk about your routine. Is your routine the problem? And because I'm also a firm believer, especially in baseball, that the workload problem isn't in game. The workload problem is all around the game. There's other sports where the game is, but it's hard for
Mm,
me, and I would have strong argument against anybody that told me otherwise. But for a relief pitcher to go out there and throw 16 pitches, max effort, and then be done with their game and jogging from the bullpen to the mound, and that's that, it's tough for me to say that that's the workload that's hurting our players.
that's breaking them.
That's, you know what I mean? Like,
It
that's where I look at this and I go, we've got to reimagine this, because
yeah.
what we're focusing on and villainizing out there is not really it.
It's funny that you say that because my wife was a former college softball pitcher.
Yeah.
And she's just blown away because I talk about our baseball team and how we've got 34 guys on our roster and we need more pitchers. And this, she's like, how many pitchers do you have? And I start telling her, she's like, she came
Yeah.
from a world where there's 2 pitchers, right?
Yeah.
And she would throw 16, 18 innings in a day
I know.
sometimes and come back
I
the
know.
next day and do it all over again. Now, completely different movement, all of that. We
Hmm.
understand the game is different. So, but to your point, a guy comes in and throws 16 max effort throws. It is hard to believe that that's what's crushing. Oh, but then take a position player, right? 4 to 5 at bats in a game. And then in the field, like they may make what? Depending on their position, if they're an
Yeah.
outfielder, they might make 3 or 4 plays in a game.
I know.
Like,
I know.
so standing out in the outfield and running down a fly ball and have 1 or 2 um throws from the outfield inside into the infield with intent a game, like
Right.
that's not workload.
No.
So it's interesting you say that, and I love that idea of really just instead of um a starting pitcher running 2 miles the day after their start. Is that the right thing for them to do?
Right.
Maybe it is,
Right.
maybe it isn't. But just because that's always the way we've done it doesn't mean that
Right.
that's always the way we should do it. And especially when you look at guys that have miles on their body, right? And so you're looking at
Exactly.
guys that are trying to play 10, 15, 20 years. That
Hmm.
has to change over time. They have to get smarter with how they handle their body as time evolves. So then within your practice, and I know you really are a movement load the tissue guy, but there is room for soft tissue work. So, and I'm going to be
Sure.
biased because we're here for Fringe, right? But I love red light, but that's not my goal here. Like, what are the tools you use? I mean, as far
Mhm.
as what are your guys using? What are their go tos? And it's probably different versus Dominican versus big leagues, but kind of generally speaking, you said the things that you're equipping your guys with, they all have to work, they all have to hit, right? So what does that look
Right.
like? What are the modalities, the tools you guys are typically using?
Sure, and I think it's definitely shifted away from, uh, quote unquote pain modulation, as like our focus. Like when I got into athletic training, it was, the stims and the ices and how can we just take pain away and how can we stop inflammation from happening versus now we're much more like we're creating inflammation now. I mean, that's kind of our treatment process to some regard. And um I think there's a difference between throwing a kitchen sink at a player, but also stacking the deck. And I think that
Mm,
that's, you should know what is creating the change or the improvement that you want. So just doing 10 things. If I had a player come down and I'm dry needling first, and then I'm doing some sort of ART passes, and then I'm doing some sort of shockwave therapy, and then I'm doing lymphatic drainage or some sort of lymphatic massage on it. And I don't know exactly what's going on there or what's creating the change, right? But I think stacking the deck, if I do believe in it that athlete responds well to one of the modalities, and again, I know we're here for Fringe, and it's actually an easy one to say versus some of the other modalities that we utilize, is because it's such an easy add-on to what the athlete's doing. And it's such an easy piece to add to their treatment process when they're not doing any treatment. If we're being very invasive on a player through needles, through shockwave, through anything that's really invasive and really can cause soreness and cause kick up inflammation, all that kind of stuff, and we want to give that player X amount of time in that day down, or if we want to give that athlete a really good, just straight up recovery day the next day, there's really so many avenues that you can use red light therapy of just like, hey, look, you're going to do this. You can travel on the plane with it. You can do it at
mhm.
home. You can do it. So it's not a patient clinician, interface that has to happen for it to happen. Right. So, that's where a lot of what can we do? How can we make the player, how can we make the tissue recover better when we as clinicians aren't around them? And anytime that we can do that or have our hands on them or doing an intervention right away with them, right? What can we do to allow them to then, and this is where I would always challenge anybody that says, well, like they just need a treatment day, they don't need to do anything else. It's like, no, we're doing treatment to put the tissue in a better spot and put that athlete in a better spot to go load the tissue. I'm not saying
Mhm,
that we have to max effort or we have to do,
mhm.
90% plus of whatever intensity we're trying to do, but tissue wants to be loaded, but it also wants to be recovered. And it's like
For
if we're
sure.
doing all of this stuff, we can then do that stuff. And again, that's pie in the sky to some regard. There are days where it's like, hey, look, this guy just threw 9 innings. He's just going to lay on the table and just get loved on. Totally understand that, and that's part of it because it's a long season and all
Occasionally
that.
that can happen, but that shouldn't be an
But
everyday
if
thing.
right, and if we're truly trying to create a vision and a mission for our department, that's how we had to do it. It's like, okay, if we're going to do be really intentional with what we do workload wise, well, we got to be really intentional with what we do treatment wise too. So that's what's been a really great shift for us is that we're utilizing things and our why is really strong with why we're doing it. So it's dry needles, it's the Mark Pros or the pumping
Mhm,
machines to
mhm.
try to get blood flow. It's it's the blow up boots. I don't want to say
Yep.
the names, but it's
Yeah,
the um
pneumatic devices,
pneumatic
yes, all good.
devices. There you go.
Yes.
So it's those kind of products that we're using constantly. But again, and this is what's terrible because it's what we do for a living, and I hate always saying this. It's like, you know what? The most inexpensive, best way to recover is eat better and sleep better. And
Amen. That
that's,
is true. No
it
question.
is true. And that's also a big part of our process is education, right? It's
Yeah.
constantly educating on their food choices and how much sleep they're getting and how much rest they're getting. And it's okay to get 10 hours of sleep as an athlete. It's fine. do it. We
Yeah.
want that,
Right. Right.
so
So
that's kind of what it looks like.
one of the things you said, I think is, I mean, I'm noting this because I think you put it really well. There's a difference between throwing the kitchen sink at somebody, but also stacking the deck. Those are different
Yep.
approaches. And I think you and I can both agree in our younger years, it's like, well, I don't know
Oh,
what to do. So we're just going to just
I
throw
got 10
everything we
things. I'm
can
using
think
all
of,
10
right?
things. Yep.
You're
Yep.
right. And I've got a hammer and everything looks like a nail. And so here we go. And,
Yep.
and then now as you get a little bit older, a little bit more experience, you start to look at, okay, well, I can use this tool for this mechanism, this tool for this mechanism. And by the way,
Yeah.
I can stack these things together. So,
Yep.
and now we are stacking the deck, right? So, interesting. And sometimes we stumble across it sort of by accident.
Sure.
But we like, just to give people an example, like one of my favorite stacks that we've discovered with our athletes for any kind of like bruising, so think like quad contusion, guys take a
Yep.
foul ball off their shin, something like that, they've got a bruise. We sort of stumbled across it last fall. If we do a dry needling, so small little 15
Yep.
millimeter needles, we do a whole bunch of them in the area to stimulate lymphatic flow, and then I do red light on over top of that. So I set my red light
Yep.
panel up over top of that. So now I'm getting some inflammation to the area to help with that. And that acute control there of the inflammatory process. And then we put BFR on that extremity and we do a
There it
recovery
is.
setting. So we'll go 4 minutes with like 80% occlusion, a minute and a half reperfusion, and we'll repeat that for 30 minutes. And
Yeah.
so what I think we're getting is, and I can't guarantee this, right? But you've got lymphatic flow. We've got inflammation being regulated. I'll use that as my term because it could be
Sure.
up or down depending
Sure.
on what we're trying to do. And then we've got tons of blood flow being flushed out of the area. Those things come back the next day looking like nothing ever happened, right? And so, but I think
You're right.
that's sort of the difference of we're stacking tools together, not just throwing stuff out. So I love
Right.
that
And
what
your
you
why is
said.
really strong. Your why is really strong.
Right.
And that's what's great. To say, well, I saw someone else do it, or this is what
Yeah.
we've always done. Like that
Right.
doesn't play. And our athletes,
Yeah.
I don't want to give them too much credit, but they are way more well-read. They're way more intelligent than
Oh,
they probably ever have been. Some
dude.
to a fault, but I really
Mm,
do think that you can't use car salesmen into
no,
a treatment plan or a rehab program. They really
but
want to know the why, and we should be able to tell them it.
no question. And Corey, 20 years ago, it was good enough that you worked for the Detroit Tigers that
That was it.
you could tell them what to do, and
Yep.
they did it. And it
Yep.
was good enough for me to be a Division I athletic trainer that they
Yep.
bought in.
That's it.
Not anymore because
Nope.
everybody's got their own strength coach. They have their own
Yeah.
therapist. They're on social media. They are well read. They've got AI that's telling them what to do. Like,
Yeah.
and some of that is hurting them, but for the most part, we have to be able to defend what we're doing and explain it because they won't buy in otherwise. And
Sure.
if we don't have patient buy-in, we're screwed. Nothing happens
No,
then. So,
absolutely. That's it.
talk to me about inflammation because you mentioned it. Like you're actually introducing a lot more inflammation than you used to,
Sure.
and I think this does play into the red light therapy conversation of managing inflammation. So, talk about that a little bit compared to
Yeah.
maybe what you've done in the past and how you guys are using that.
No, I think it's interesting in baseball too because in football you have these acute big effusions and this inflammation that really kicks up off an acute event, whereas there's so much in baseball that's chronic or acute on chronic, however you want to kind of explain it, and it's just constantly trying to like play catch up. It's never like we never have 3 days where it's like, okay, we're just gonna get this under control, and then it's just constantly bringing the gauge down, and it's gonna come back up, and then we just bring it back down again, and it's gonna go back up again. We know that, and it's the fight and the battle that we have every day with all of our players. So, but I think what really changed our mindset of how we treat these athletes is understanding that again, inflammation wasn't the villain. Like it wasn't the
Mm,
thing that was causing the problem because our athletes aren't coming in and not being able to move their elbow because of inflammation. They're sore in their flexor pronator group because of acute on chronic or chronic workload inflammation. So it's different. It's how can we make them feel better, which is always great. Now, whether that's actually changing tissue or changing what's going on, that's up for debate. But, if an athlete gets off a table and they feel better, that's great, right? And by increasing the inflammation, or at least like jump starting it a little bit, I think what we see in baseball especially is like all these acute on chronic, or these chronic tendinopathies and things like that. It's a lack of blood flow. It's not a true inflammation that's causing this discomfort. It's causing this inability to function properly. So by kicking it up, I just think that it's really helping the tissue more than it's hurting it by allowing things to happen there. And again, stacking the deck. So how can we do that most effectively through different ways and different means? And it's like, okay, if we are going to kick it up, we want to make sure that that inflammation is doing good by us, so to speak. And so if we're using dry needles, or we're using BFR to increase some sort of blood flow to that area, that's going to create some sort of micro damage to create the inflammatory process. Okay, what can we do to make sure that the cells are in a better alignment and a better functionality than what they would have been if it was just like an acute injury? So that's where things like red light therapy are so great, because it's like, okay, now we know that there's going to be traffic, but now the red light therapy comes in and it kind of is like, I'm the traffic cop. I'll make sure that everything goes
For
right
sure.
here.
For sure.
And that's where I think we've kind of changed our mindset of even going from, well, we're going to create inflammation because it's needed for the healing process. Like, yeah, that's fine. But how are we leveraging the healing process? What are we doing to make sure that we're just not kicking up the inflammatory process, but we're actually kicking up the inflammatory process, and in the same breath, making sure that that's benefiting us and not hurting us?
Yeah, so I'm guessing there's not a lot of ice and NSAIDs in your
No,
training
we've
room
gotten away
anymore.
from that quite a bit. Ice is for our post-game drinks. That's about it. That's what we use
That's
ice
great.
for, you know?
That's where we've evolved to, right? And
Yep.
I tell people all the time when they're asking me, well, where do I put red light therapy in my clinical flow, right? Like, where does this fit? And I was just telling them, hey, the easiest place to start is the things we used to heat and ice, replace that with red light
Yeah,
therapy, because you're
exactly.
going
That's
to
what
get a
we've done.
similar pain relieving effect, but now we're getting a lot more out of it. We're getting healing properties. We're upregulating that cellular metabolism, working at a cellular
Yep.
level. And now if we need more inflammation to the area, which again, I think historically there's been a misunderstanding of what inflammation really is. We need
Exactly.
inflammation for tissue healing
Yes.
to take place. It does not happen without it. And so if we need more inflammation to the area, red light therapy can do that. But on the flip side, if we do have an area that's like super inflamed and just over the top, one of the most predictable things in the research is that we can kind of bring down that inflammatory process if
Yep.
needed in that situation. So that's why I like to use the term of regulatory modality. And I stole that from Genevieve, our science director at Fringe.
Hmm.
She talks a lot about it regulates that process. And to your put, I like how you put it too. If it's the traffic cop, right?
Yeah.
And so it helps just sort of direct traffic and make sure that everything is working at an optimal level, and it optimizes things down at that cellular level. And I really struggled early on with red light therapy of, you know, anything that says we can use it for acute injuries, chronic injuries, brain
Oh,
health,
I
gut
know.
health,
I
reproductive health. You
know.
go,
I know.
I'm out. I can't, I'm not doing
Yep.
that. And to
No, I
your
know.
credit, Corey, to your credit, when I first started working for Fringe, you were one of my first phone calls, and you took
Yeah.
my call because of our history. And you were like, I don't know, Mitch, but if you say this works, I'll give it a shot. And I'm grateful that
Yep.
you trust me and you gave it a shot. And it sounds like it's gone well for you guys. But it wasn't until I started getting into the research and seeing that we're really operating at a cellular level, then it helps me understand that really what's happening with red light therapy is if it's an osteoblast that I'm trying to impact, I have better bone health. If it's a fibroblast, I have
Hmm.
better connective tissue health. If it's a red blood cell, I carry oxygen better. If it's a brain cell, I have better brain function. And so when we get down to that cellular level, now I can start to go, okay, well, this is actually pretty cool. We can actually do a lot of different things with our red light therapy. But it sounds like you guys are seeing a lot of the same things that I've seen clinically with it in that regard.
Yeah, and to be honest with you, I'm not gonna lie on this podcast and say that I've been on red light since the inception and the introduction to
No.
sports medicine, because again, it's very difficult for me, which is why ice was always one of those modalities where I was like, man, it's tough for me to think that this is getting much past the skin level, right? And that's where, to me, the skin is a pretty good barrier. It's there for a reason, you know? And so it was always difficult for when I learned iontophoresis and phonophoresis and all these different things that it was like, oh, we're driving it through the skin. I'm like, no, we're not. Like, who are you kidding? And I think that that's what with this, and maybe it's just because um, some of these modalities have gotten more love on social media and it's in your face more.
Mm,
And
hmm.
so I'm seeing it more and I go, okay, well, all right, that guy I think is pretty smart. And all right, that person I think is just out for a paycheck. But you know what? Then I started seeing more and more of the, no, I think that guy's pretty smart, like leveraging this. And it was, okay, let me dive in a little bit. And again, our athletes, although smarter and more in tune with their bodies and more in tune with what's going on, at the end of the day, the next day, if they feel better, they don't care what it was that we did with them that made them feel better. Like it
Yep.
is a money in, money out type
Yep.
situation. It is a
Better is better.
transactionary thing. Better is better. They do not care how it happened. And I think that that's what's really important with it is that once we started seeing adding that to things that we already kind of thought worked, it was like, oh, okay, there's something here. There's something to this of adding red light therapy to our treatment paradigm because that's going to, again, just stack the deck.
Yeah. Is there any specific things that your guys are using red light therapy for, like out in, out in the wild, so to speak? Like you get
Sure.
into your minor league guys, and then, I mean, is it like this injury or this condition, we're always using that, or maybe we've replaced these tools that we've traditionally traveled with, and now we're using red light? Is there anything specific you can think of
Yeah.
that people might, be interested who are still a little bit new to red light and want to learn more how to integrate it?
Yeah. I mean, we're using it a ton for our post-op UCL reconstructions. We're putting it right over the
Mm,
elbow. It's
for sure.
just, especially now with um, the surgery has evolved and there's more going on within the elbow when they do the surgery. Now they don't just reconstruct the ulnar collateral ligament with a harvested tendon. Now they're also putting an internal brace, which is like
Mhm.
a little fiber wire to strengthen that area. Um, and with a lot of tissue comes a lot of robust tissue in those drill holes and all that kind of stuff. And so we're seeing more flexor strains as well. So there's flexor damage on top of these ligaments where we used to see back in like late cocking when the arm was up at 90 and back here. That's when we were seeing our injuries. Now we're seeing them out front where it's almost like this eccentric pull off the medial epicondyle. And that's what's causing this rip because of these huge pronated pitches that we're seeing and these big supinated pitches that they're
Mm,
holding these these movements for so much longer now that it's this eccentric pull that we're seeing. So a lot of the tendon is coming with the ligament when we see it, especially on the proximal end. So there's just more damage going on in the elbow than what was once traditionally our Tommy John surgery or ulnar
mhm.
collateral ligament reconstruction. So
Yep.
with that becomes just so much more stuff to heal. It becomes just way more robust in that area. There's players are bigger, faster, and stronger, so they're able to move along with the rehab a little bit faster. So again, just because they're stronger doesn't mean biology cares about that, right? So that's where
Mhm.
we have to really be intentional with that and hitting that. And we even have pitchers that are 2-3 years out that will still day after they pitch they'll red light their elbow. Before they go out to pitch they'll red light their elbow. So we're
Mhm.
definitely using it for that. But also you brought it up before. It's really taken the place of ice. So guy
Mhm.
fouls ball off his shin, we're putting that on it. It's not going to be a big bag of ice or the old English
Mhm.
cap. The thing is
Yeah.
so yeah, we're going to leverage that, and it travels really well. That's the other thing with baseball. Football, you travel once a week. You know when you're traveling, the
Yeah.
truck goes, all this kind of stuff. You can bring
Yeah.
everything. For
Yeah.
baseball, if we can't travel with it, it's a really tough thing for us to buy because we can't have it for 81 games and not for the other 81.
For sure.
But again, this is where, when we first talked and you kind of showed me, that was the other thing. I'd only thought of red light as these big beds and these big this and
Mhm.
that. And, or, clinician to patient one-on-one time for treatment. And I was like, well, I don't want to waste this guy, especially if I don't know if I believe in this yet. And then also, I don't know if I'm going to have money to buy this bed or whatever. And then
Yeah.
when you were showing me what you were showing me, that's what also changed my mind because it's like, okay, this is cost effective, this is portable, this can be used every single day for every single athlete at some sort of spot in their treatment program. So that's what really kind of opened my eyes and shifted our focus to it.
Yeah, no, that's good. And I personal experience, we actually have on our on the Fringe website a case report of an elbow post-op UCL repair, which happened to be my 16-year-old son.
Oh, there you
So
go.
he had he avulsed his UCL the
Oh,
distal
wow.
end, and when he was 16, he's a catcher, and like, listen, you know what travel balls right? Like
Oh, yeah.
he rolls stride, starts playing high school ball in February, catches every game all through
Yep.
the high school season. We finish in districts on a Thursday night, and guess what? Saturday morning, we're playing a travel ball tournament, and
Yeah.
then we're playing 5 games in a weekend, and he's catching every game, and at some point, and I hate it, right? Like I'm sitting here going, I know better. I know this is a bad idea, but
Hmm.
unfortunately, in our youth sports world, if you don't do some of those things, you don't get the opportunity
Sure.
to be recruited or to be able to
Yeah.
compete
No,
on
you're
those
not
levels.
wrong.
So
You're not wrong.
it's a really challenging position for us to be in as sports medicine providers and clinicians with our own kids. But I use red light with him after surgery. I mean, once a day, every day, and his outcomes have been phenomenal. And does that mean that that's the only reason? No, but I will say early on, man, it's so good, and I think a real game changer from what we've done in the past with
Love it.
ice and all of
Yeah.
those types of things. So for sure, a big game changer. And one of the things too, I need to we recently in February launched our red light mats, and this is we're actually currently sold out of them. But we need to get you guys set up with a red light
Yeah, we
mat,
do.
because you think
Yeah.
about the beds, right? The beds, I actually think right now, as it stands, and I always reserve the right to change my mind based on whatever
Sure.
information comes out next week, next month, next year. But I actually think we're going to evolve to a point where full body red light therapy is actually where it's at. And,
Yeah.
I think there's such a systemic effect. We have so much inflammation in our bodies because of the amount of sugar we consume and the caffeine and the crap that we're putting in our bodies and the lack of sleep. And for you guys traveling, all that stuff, I think once a day, and what I've noticed since I got my red light mat, and it's just like a yoga mat, right? With a lot of red light in it, but you can roll it up and we can hang it on the
Yeah.
wall, or we can whatever. So it's the same mentality as the beds. I talked to some P4 schools that have $80,000 invested in a red light bed, and I'm like, man, I wish I could do
Hmm.
that.
Yeah.
But they also have a dedicated space for it. Well, it's the same mentality, right? But now we can pick it up, put it down. It's cordless, it's
And
wireless,
that's what
but
we need. That's what
yeah,
you need.
but now you're I mean, I got mine, and I'm 48 years old. I've had 6 knee surgeries. Like I've got some miles on my body, and when I lay on that thing, my body feels amazing. And not
That's
that even
great.
my knees are getting that much exposed because I'm 6'5", my knees hang
Right.
off.
I was about to
Um, but
say.
but we think about just exposing our body systemically
Yeah.
to enhance that metabolism, the mitochondria producing more ATP.
Yeah.
I do think we're going to evolve to the point where that is where it's at. And but science isn't there. The research hasn't caught up yet with that. But I do think that's something that where we're going to be able to manage this inflammation a lot better
Yeah, I
in the
agree.
long term with those types of things. So, um, are there anything that you mentioned it travel wise, things like that? Is there anything, ice, obviously, is there anything else that you guys have kind of said, we're not using those tools as much as we did
Yeah.
maybe 5, 10 years ago because we've had red light, or has this just been more of an add-on for you guys?
No, that's definitely, I mean, I think it was even before red light, but, I mean, I can't remember the last time that we turned on an ultrasound machine, not
Oh
a
yeah, of
musculoskeletal,
course.
not a
Right.
diagnostic ultrasound, but I
Yeah, of
can't
course.
remember. I don't even think we have one, right? E-stim has really kinda died except for with dry needles. We'll E-stim with dry
Hmm.
needles, but,
Yeah.
IFC and all that kinda stuff is just really not it anymore. So I think that, those are kind of modalities that have made their way outside. But the thing that's great about red light is it's like a condiment to some of the other therapies that we're doing, and that's what's great about it. It's not an add-on standalone. It's an add-on in conjunction with, and I think that that's what's been great about it because it's not invasive. It's not. or at least it doesn't feel it, right? It's not to the point where we're hurting tissue or hitting on tissue more. If I do a really deep massage and I know that that's going to bring some sort of symptom on the back end of maybe soreness or maybe even tighten up a little bit by the next day kind of thing, that's fine. But I know that the red light's not going to do that, but it's definitely going to help. So that's where I think has been the biggest bang for our buck. Is it's such a great add-on to what we're already doing.
I love that idea of the condiment. I'm making notes of all these little nuggets you're giving me because you're wording things in a way that's just absolutely awesome. But yeah, the condiment, right? Like
Yeah.
you got your hot dog and we got to put the it's good. A hot
Yeah.
dog is good, right? Like
Yep.
I made them for
Yep.
me and my kids last night, but
Yep.
they're a little bit better when I add some onions, some relish.
No doubt.
Maybe
No
I'm a
doubt.
ranch guy, so ranch can go on anything,
Sure.
so I can put a little ranch
Sure.
on there. And that's I think a really cool way of looking at it. So well, I mean, we're getting up on the 1 hour mark here, which
Sure.
is
Yeah.
I think
I figured this was
people
gonna
will
be
probably
a pretty good convo. I didn't think it was gonna be very
oh,
difficult to
of
get through
course.
an hour.
Right. No, it's easy for you and I to talk. And I
Yeah.
gave you a list of some ideas and some things I want to talk about. I think we got through a third of them, so we could do this again another
Perfect.
time. But I'm sure some people may get sick of listening to you and I just talk for the sake of talking.
Yeah,
But
right.
is there anything else, any other nuggets or any thoughts you have on, red light therapy or just sports medicine, clinical world
Yeah.
in general that you've seen that's, that's good for us to kind of mention or talk about?
No, I think stay open-minded. I mean, that's I think the thing that all athletic trainers want to say, that they're open-minded and they're constantly learning. And you hear all these buzz terms and buzzwords, but then they always gravitate back to what they think works or know works. And it's like get uncomfortable, a little bit. Get
Mm,
really comfortable with being uncomfortable,
yeah.
and really challenging how you think. Challenge what you believe, because that can go a really long way. And the other piece too, especially for our young clinicians out there, don't be scared to speak up, because inexperience, that can be a real superpower, because you don't have biases. You don't have things that
Mm,
you think work or don't work or haven't worked, or oh, we don't do that anymore because it didn't work. Okay, well, you know what? Speak up to some old guy like me, and say like, no, why don't we look at this again? Because here's the why. And I think that those are pearls that I try to always reflect on, because I want all of my staff to do that. I want them to think independently and critically, and I want them to come up with ideas. And I think that everybody in sports medicine always uses these taglines of all the time of oh, I'm a career learner and I'm this and that. And it's like, well, okay, then be about it. Then
right.
really open up your mind, be willing to
Show it to me.
change. Yep. And I would say that this is one of the microcosms of that kind of bigger picture thinking of, I was not a big fan. I didn't believe in it. And now, from changing the way I thought, I think better now.
Yeah. Well, and I've said forever, our greatest moments of discomfort are also our greatest opportunities for growth. And
That's it.
that's what you're saying right there. And also to hit on something you mentioned earlier of just going back to kind of the red light conversation is we've never been in a world where we all have had so much access to information. And I think
Yeah.
because of that, some guys like you and me that are in a different, kind of a little, I wouldn't say a late stage in our career, but we've been around
Hmm.
a while.
Sure.
We're naturally, going to be skeptical of something we see on social media, right?
Yep.
And red light therapy is all over social media. Why? Because it
Sure
looks
is.
really good, right? It looks
Hmm.
awesome on a picture on Instagram. And we know that. So people are using that, but then us as clinicians, we naturally kind of push back like, well, it's great for Instagram. That doesn't mean it actually works. But
Right.
in this case, I think you and I agree that we've actually seen some pretty amazing outcomes with it. And it
Yep.
has been a really good tool and valuable tool for us. So, all right. Well,
Absolutely.
on that note, we're going to sign off. Corey,
Great.
thank you so much for the time. I always enjoy our conversations. Hopefully, I can see you soon in person at a conference or wherever else we might be.
Absolutely,
And
Mitch.
um, I, um, I do have some Marlins gear that's still in my closet that I pull out every now and then, and
We'll have to get you
because
new
when
ones. We'll have to get you updated. Yep.
all right. Well, I never shy away from gear, but one of our former guys used to play for you guys, so I still have some Marlins gear in my
Great.
closet. I pull it out every now and then and cheer you guys on just because of our friendship. So
Wonderful.
I'm grateful for the opportunity, and hopefully we can do it again. And to everybody listening, thanks for dialing in. Thanks for listening to a couple of old athletic trainers sitting around just shooting the breeze and catching
Yep.
up. So, without further ado, hope everybody has a great rest of your day. And thanks again for everything, Corey.
Great. Thank you.